Good afternoon, and welcome to the first in a series of webinars provided by the Section of Chronic Disease Prevention and Health Promotion. We're happy you've joined us today. With me is Andrea Finati, Deputy Section Chief, and my name is Kathy Alloway, Chief of the Section. We are pleased to launch this webinar series. We'll be offering webinars on the third Tuesday of the month at 1 p.m. to feature some of our ongoing work in chronic disease prevention and health promotion. In addition to sharing our work with you, we hope these webinars will spark your interest in learning more about our projects, as well as opportunities for collaboration. This webinar is planned for 30 minutes, a 20-minute presentation, followed by 10 minutes for Q&A. A few technical items. You should be hearing the webinar through your computer speakers or headset. If you are experiencing any technical difficulties, please let us know through the chat box or question box as shown on the slide. This appears in the GoToWebinar box that shows up on the corner of your screen and might be minimized. So we're going to do a sound check here. Please raise your hand if you are able to hear us, and if you have trouble finding the raise your hand button, it shows up on the next slide. So are we are, yep. Thank you. Excellent. I'm glad to know people are hearing this. So we have muted everyone. If you want to ask a question, please do raise your hand and we will unmute you for questions at the end. Today's webinar will be an overview of the burden of chronic disease and injury and a brief introduction to the section's priorities and activities. It's our hope that you will be encouraged to review our website, to use our materials and resources, to identify opportunities for collaboration, and be in touch to gain a deeper understanding of our projects and programs. I'll begin with a brief overview of the scope of work within the section. There are three primary aspects to our work. Beginning at the bottom, because it is the foundation of everything we do, is data and surveillance. Andrea will be sharing results of our data collection and analysis. Next is chronic disease prevention. Our work in cancer, diabetes, and heart disease and stroke is funded primarily through CDC grants with prescribed strategies and performance measures. We're focused on changing policies and systems, including healthcare systems. Last but not least is health promotion. Here we emphasize promoting the conditions that lead to health and safety and healthy behaviors. This includes tobacco, obesity, and injury prevention, and school health. And of course, evaluation is critical to all aspects of our work and embedded into all programs. So why do we care? We care because half of adults have one or more chronic diseases, and 1 in 4 have 2 or more chronic diseases. And we care because there's a strong connection between health behaviors and chronic diseases. As you can see, it is hard to sort out just one factor that influences health outcomes. So we developed this infographic to illustrate the interrelationship between health behaviors or risk factors and chronic diseases. And this graphic depicts a primary reason that we work less in silos and more by integrating our work across programs. This infographic is available on our website. The section collects data on some critical measures of health status among Alaskans. The Alaska Cancer Registry tracks cancer incidence. The Behavior Risk Factor Surveillance System measures risk behaviors among adults through a randomized telephone survey. The Student Weight Status Surveillance is a collection of weight status among some participating school districts that we help with. The Youth Risk Behavior Survey is among mostly high school students, and it tracks their behaviors. And we disseminate all this information through the Informed Alaskans initiative, which are health maps and indicator reports. And now I will turn this over to Andrea, who is our chronic disease epidemiologist, to share some data highlights.
Good afternoon. I'm Andrea Finati, and as Kathy said, I'm the Deputy Section Chief and the Chronic Disease Epidemiologist here at the section. So now I'm going to walk you through a very high-level overview of the health status of Alaskans. This overview will cover the following topics, all of which are essential to consider in order to get a complete picture of the health of any population. I'll start by just touching on what we know about what kinds of factors make us healthy or keep us from being healthy. How much of a contribution does each factor make in terms of determining our health? Then I'll do a very high-level review of health status in Alaska, starting with the most extreme outcome, death or mortality, and moving slowly upstream through morbidity, then to the risk factors that contribute to those health outcomes. So, what determines our health? This graph shows the relative influence of a number of factors on determining premature death in the U.S. It's a bit dated now, but in 2002, McGinnis and colleagues wrote an article that made the point that there was an imbalance of social investments in medical care versus prevention or health promotion activities. So despite the fact that shortfalls in medical care only account for 10% of premature deaths, the overwhelming majority of what this country spends on health, 95% or so, goes to direct medical care services. On the other hand, we know that behaviors like tobacco use, diet, and inactivity contribute much more to premature death, yet we spend basically decimal dust on approaches aimed at addressing those factors. A quick glance at the leading causes of death in the U.S. confirms what we just saw in the previous graph regarding contributors to premature death. You can see that heart disease and cancer are far and away the top killers of Americans, and we know that behavior contributes significantly to both. So then what truly causes all those premature deaths? A group of CDC researchers took that question quite literally and set out to determine the actual causes of preventable death in the U.S., the risk factors that are linked with those leading causes of death. And here's what they found: that tobacco, poor diet, and inactivity are responsible for the lion's share of U.S. deaths, taken together 69% of preventable or premature deaths. The Oxford Health Alliance, which is a global public-private partnership battling chronic disease worldwide, came up with this handy way to summarize all of this: 3, 4, 50. That's the 3 risk factors, tobacco use, poor diet, and inactivity, contributing to the 4 chronic diseases, heart disease, diabetes, lung disease, and some cancers, that are responsible for 50% of the preventable deaths in the world. So with that background in mind, let's turn to what our Alaska-specific data sources tell us about the health of our population, starting with what Alaskans die from. These are the leading causes of death in Alaska. If you read the table from left to right, you'll see the cause of death, the number of Alaskan deaths in the most recent year for which data are available, what that means in terms of an age-adjusted rate, and then how that compares to U.S. age-adjusted rate and rank. In a lot of respects, we're not all that different from the U.S. By far, the top 2 causes are cancer and heart disease in both the U.S. and Alaska, although you'll note the rankings are switched. Cancer is number 1 in Alaska. Unintentional injuries are also 3rd in Alaska, where they're 4th in the U.S. We have made a lot of progress in Alaska in this area, but as you can see, we still have a ways to go. Suicide is clearly an area where we're doing much worse than the U.S. as a whole. Our age-adjusted rate is double that of the U.S. And chronic liver disease and cirrhosis is much more of a concern here than in the U.S., where it doesn't even make the top 10 causes of death. One way to summarize all of this is to say that in Alaska, about 4,000 residents die in a year. 6 in 10 of those are due to chronic disease. Deaths from injuries, both unintentional and intentional, make up another 15%. The remaining 25% is everything else. When we look at mortality rates, each death is treated equally. So in a way, it's a very crude measure of health status. For example, just thinking in terms of how deaths at different ages impact economics due to lost productivity, the death of a newborn, a 20-year-old, and a 75-year-old have very different implications. That's why we also look at years of potential life lost, defined as number of years of life relative to some arbitrary cut point, like 75, lost prematurely. So through this lens, we see that the greatest impact from deaths due to unintentional injuries, which strike many Alaskans down in their early years. And of course, Counting deaths in any manner only gives a pretty incomplete picture of the health status of a population. Just as an example, if you look at injuries that result in death, on the left-hand side of this slide, suicide far surpasses falls as a cause. But if you switch to looking at non-fatal hospitalizations for the two causes on the right, you see the reverse pattern. Many more falls than suicide attempts end up in the hospital. They're just not as likely to result in death. So now we'll move on to morbidity, or the presence of illness or injury. One of the sources of data we have for looking at morbidity is the hospital discharge data set. This contains information on the discharges from the majority of Alaska hospitals. This table shows the top reasons for discharge from the hospital in terms of number of discharges and also proportion of charges spent on each discharge category. Childbirth and newborn conditions are typically first, but beyond that, you can see circulatory diseases, heart disease, make up 11% of discharges, but closer to 20% in terms of cost. We also get data on cancer incidence from the Alaska Cancer Registry. This table shows the top 5 cancer sites in terms of cases. So number 1, breast cancer among women, lung and bronchus are second, then prostate cancer among men, colorectal cancer, and then 5th is urinary bladder. We also get some data on the prevalence of certain conditions from the BRFSS, where we ask about each of a variety of experiences and diagnoses. Here we see the number of Alaska adults who've been diagnosed with each of these conditions, which is certainly an underestimate because it's a self-report. So for example, 160,000 adults have been told by a healthcare provider that they have hypertension. Hundreds of thousands of Alaskans are dealing with chronic conditions, and many more than one of these. We're also able to monitor the rate of substantiated reports of child maltreatment by looking at data from the Office of Children's Services here in the Health Department. This indicator is one of our Healthy Alaskans 2020 leading health indicators. We see that Alaska's rate of child maltreatment remains higher than the U.S. rate by a considerable amount. The BRFSS also includes a number of measures that get at quality of life and disability. For example, 1 in 10 Alaska adults meets this definition of poor mental health, half of the days in the past month being poor mental health days. A little over 1 in 5 meet the definition of having a disability. That is, that their activities were limited due to health problems or that they had to use some sort of specialized equipment due to their health problems. If we continue to move upstream, we get to the risk factors underlying and contributing to many of the health concerns we have just reviewed. This chart shows the prevalence of a number of behavioral risk factors among adults. The vast majority of us are not eating the recommended servings of fruits and vegetables. We consume an awful lot of sugary drinks. And 1 in 5 of us are completely inactive. Not surprisingly then, 2/3 of Alaska adults are overweight or obese. About 1 in 5 of us also smoke, binge drink alcohol, have a history of physical or sexual abuse, or don't always wear a seatbelt. Most Alaskans have more than one risk factor. From our Youth Risk Behavior Survey, or YRBS, we see a very similar pattern of risk behaviors among our high school students in Alaska. Of note, about 8 in 10 high school students are failing to get the recommended 60 minutes of physical activity every day. In terms of getting our recommended screenings and healthcare access in general, these measures show that Alaska is consistently a little bit behind the U.S. overall. These rates are not age-adjusted, however, so may reflect the fact that Alaskans are relatively young compared to the U.S. as a whole, and many of these screenings do occur more frequently in older age groups. But we also see that our rates of vaccination coverage for children are below the U.S. The break at 2009 represents a change in the vaccination series recommended for children. And we also see a consistent and alarming pattern of low rates of prenatal care among women in Alaska. For 1 in 5 live births, there was no prenatal care in the first trimester. Now at this point, I would love to take that final step all the way upstream to consider social determinants of health, which help us address the issue of health equity. Wouldn't that be an interesting discussion? Unfortunately, we don't have time to have that discussion today, but I'm just going to throw out a teaser so you can look forward to that in the near future. And I did want to leave you some links to resources that can provide you with more information, such as I just shared, and really quite a bit more. First, if you haven't, please visit our webpage. You can just Google Alaska Chronic. From there, you can access any of our program-specific pages, for example, the Tobacco Prevention and Control Program, all of which have their own program-specific data reports and summaries. Next, please explore our Informed Alaskan sites, which has two resources, Health Maps and IBIS. Health Maps, just like it sounds, allows you to pull up a variety of health indicators for Alaska and display them in a number of geographic formats, public health region, census area and borough. IBIS, or the Indicator-Based Information System for Public Health, provides both a query tool and a set of brief indicator summaries or profiles that show trends for a particular measure, such as suicide, but then also provide context, like what's the public health importance. Finally, those data resources and more are available from the Healthy Alaskans 2020 website. Please go out there, become familiar with Alaska's 25 leading health indicators, and bookmark that page so you can see our progress on those indicators over time. Now I'll turn it back over to Kathy, who will describe areas of focus within our section.
Thank you, Andrea. The section's strategic planning process, which we undertook 2 or 3 years ago, led us to 4 major goals, and these do not encompass the entire scope of work undertaken in this section, but rather where we wanted to increase our efforts. So you can see the 4 areas are to reduce childhood obesity, to increase preventive screenings, to reduce disparities in tobacco use among 3 disparate population groups, and to reduce hospitalization due to falls among older adults. Play Every Day is the section's campaign to motivate parents and children to get active, participate in the Healthy Futures Physical Activity Challenge, and reduce consumption of sugar-sweetened beverages. You may have seen these ads on television, the ad equating an amount of sugar in a 20-ounce soda to 16 mini donuts, for example, and our most recent ad highlighting children of all abilities being active. Play Every Day is one component of a larger obesity prevention effort. In addition to this extensive social marketing campaign, the section has provided grants to school districts to combat childhood obesity and measured student weight status in about 9 school districts. Other obesity prevention efforts encourage early childhood educators to get children more active, to support low-income individuals' access to farmers' markets by enabling the use of the Quest card to purchase fruits and vegetables, support of the farm, fish, and salad bars to schools, and extensive support to the Food Policy Council. Second goal is to increase preventive screenings. The section created a public service announcement urging individuals to get a physical exam annually where the screenings are typically prescribed. We also developed a number of information materials, an example of which is on your screen. You may have seen the public service announcement that reminds adults to make an appointment for a yearly exam, during which screenings typically take place. The video on this PSA is on the section's website. The tobacco program uses a comprehensive, sustained approach that includes community interventions to achieve policy and environmental changes, such as tobacco-free policies. We do this through a grant program that funds 16 regional and statewide efforts and involves over 200 communities. Our extensive social marketing campaign includes broadcast media, print, and social media to change social norms. We support the Alaska Quit Line, offering cessation counseling and nicotine replacement patches and lozenges. Our third goal is to address the high disparities of tobacco use among some population groups in Alaska. We're employing multiple strategies to accomplish this. Many people are surprised to learn that there are still communities throughout Alaska that are not smoke-free. Senate Bill 1 was introduced in this year's legislative session, and if passed, would create a statewide smoke-free law. Following the adoption of a resolution by AFN in 2011, 109 tribes have since passed tobacco-free resolution, which is approximately half of all the tribes in Alaska. And the University of Alaska Board of Regents voted to make all campuses tobacco-free beginning in December 1st of this year. Our final goal is to reduce falls requiring hospitalizations among older adults. Although we have a number of injury prevention projects, falls are the leading cause of non-fatal hospitalization due to injuries in every age group, except those 15 to 34 years old. This past year, we have funded the Wasilla Area Seniors Center to conduct fall prevention activities among older adults throughout the Mat-Su area. With the silver tsunami coming, this becomes even more important in Alaska. CDC provides a number of evidence-based strategies, including fall risk clinics and specific exercise programs to improve balance and strength. So this has been a brief introduction to the section's priority goals and work. We hope you will tune into our future webinars and invite your colleagues to do the same. Other ways you can stay connected to our work is through our monthly newsletter. You can sign up for this on the section's website. Our next webinar will be on July 21st at 1 o'clock and will feature a closer look at the section's Play Every Day campaign. And one final thought before we turn it over for questions, to remind you that during the summertime when you're out on the water, please remember to wear your PFDs. Thank you for your time. We're happy to take your questions now. Again, to ask a question, please raise your hand. We are not seeing any raised hands. You could do that. Okay, we're going to return to the first slide to show you where to raise your hand in case any of you have forgotten. Somebody has a question. Looks like Caitlin McKenna has a question. You need to unmute her. Oh.
I don't know if you can hear me.
Caitlin?
Yes.
Do you have a question?
Oh, I just wanted to say I appreciate the information you presented. It's very helpful.
Okay, thank you.
Yes.
Any other? Sean Johnson. She's muted again. Sean, are you there? Okay. Are there any other questions? Oh, yes, we do have some. Martha Pearson. You're unmuted. Go ahead and ask your question.
My question is, how was the, I typed it in as well if you, it's better to read it. How was the, on the causes of risk slide that showed 5% is, I forget the numbers already, but you know, a pretty low percentage is the hospitalization, access, and things like that. Social behaviors versus, or social environment was one, and environment was one, and I was just wondered how those were differentiated.
So that's a really good question. Hi, Martha. This is Andrea.
Hi, Andrea.
I probably would have to go back and refer to that McGinnis et al. Paper. So the distinction between environment and social circumstances, I'm thinking environment may be more physical environment, environmental exposure kind of things, where social circumstances includes more social determinants of health, sorts of poverty, education level. That's my recollection, but I would definitely want to go back and check that reference.
Cool. No, thank you. I think that's interesting. So thank you for that.
Sure. Thanks for the question.
We've received a number of questions in the chat box, and I'm going to just ask them and see if we can get answers to them. Sean Johnson asked, geography has been shown to impact health. How has this factor affected the health of Alaskans?
Boy, that's a great question, Sean. And I don't know that I have an answer for you. I'm trying to think what sort of data sources we could look at. we certainly have the ability to look at the data that we have in the health maps with WireBS and BRFIS data by geography. So it would show the distribution of those risk factors, for example. It may not, you can't really draw a cause and effect from that, but we could certainly take a look at that. And we know, for example, that we do see different patterns of risk across, depending on what we're looking at. Just for example, with tobacco use, we know we have much higher rates of cigarette smoking in the northern part of the state. We know we have much higher rates of smokeless tobacco use in the southwest. And so whatever it is that leads to those outcomes, we certainly see changes when we look regionally. Good question.
Okay, we have also a question from Anne Marie West. Can you ask your question? Hopefully you're unmuted. You have no audio. Okay, she asked a question. Could you email the link to the recorded session? She arrived late and doesn't have audio. We switched the audio to the computers. Hopefully she got that message. But yes, this is recorded. It will be on our website, and we will send a link out to all of you who have participated. So you will have an opportunity to review this. Are there any, did we miss any questions? Jareen, do you have a question? You're unmuted, Jareen. Okay, I think it's possible some people don't have mics on their computers and aren't able to ask questions. But if you have a question, you can also put it in the chat box. Yeah, we can't hear you, Jareen. I'm sorry. You could ask your question in the chat box. Also, if you have questions, you can certainly email either Andrea or myself. We will include those emails addresses in the link that we send out following this webinar. You'll also be getting a survey, just asking some quick questions. This is our first time through. Sorry for any of the technical problems that people experienced. We are trying to do this in a way that will minimize disruptions from people putting calls on hold and that sort of thing. So we're trying this out. So thank you for your patience as we work through a few of the technical issues. Hopefully we'll get them all worked out for the next webinar. But I want to thank you for your time. We're just about at the end of our time, and we're hoping to make these short and not take up too much of your time during the day. So thank you very much for participating, and we hope you will join us for the next webinar on July 21st. Thank you.